started with the ACS-NSQIP program in mid-2007. And at the time, we had a very robust surgical performance improvement committee. However, we were looking at the core measures from Medicare, and those were process measures. We really wanted to scrutinize our outcomes. And the ACS-NSQIP provided data on outcomes which were risk-adjusted, they were evidence-based, and so that was a perfect fit for us to improve looking at those outcomes. Well, it really didn't take long. Within the first year, we had acquired approximately 1,400 patients in our database. And what we found was that we were a high outlier in catheter-associated urinary tract infections. And so at that time, we became very concerned. We thought, wow, patients, they don't want to come into the hospital and get a hospital-acquired infection. We didn't know how we were doing, and NSQIP provided us with the details about those infections. So of those 1,400 patients, we had about a 2.6% rate of urinary tract infections. And that put us in a category where, compared to other hospitals and their benchmarks, we needed improvement. So that was actually the first area where we decided that we could improve using that data. The first steps were drilling down, looking at the data. We pulled those cases and we scrutinized that data, and we found that a couple things. We had some issues with unnecessary placement of indwelling urinary catheters. Our aseptic management or technique was probably not as good as it should have been. And then Foley catheters were really being left in the patient way too long. Each day a urinary indwelling catheter is left in the patient, there's an increase of about 7% of acquiring a urinary tract infection. So with that, we formed a multidisciplinary committee, and that included the surgeon champion. It was led by our surgical clinical reviewer. She brought together all stakeholders from within the hospital. So we had nursing, we had administration, who was a champion from that end. And then we used the ACS-NSQIP best practice guidelines, which was very helpful because the ACS provides clinical topics where you can improve based on things like thromboembolic events, pneumonia, and what we used was the catheter-associated urinary tract infection. These best practice guidelines are actually based on evidence provided by the CDC, by the IHI, and so we actually just used that to formulate our own protocol. Now, the protocol was very intense, and it required several hours of getting together with this multidisciplinary committee, and we talked about which patients actually should have an indwelling urinary catheter, particularly those patients who are undergoing laparoscopic surgery, patients requiring physiologic monitoring that may be sicker. And we found that even when they came to the emergency room and had a surgical problem, those catheters were being placed unnecessarily. We also looked at maintenance, education. We found that too many of the urimeters which are attached to the catheters were being left on the floor, which allows for infection. We generated through the protocol that all patients must have a secure strap so that the Foley catheters are attached to the patient at all times to prevent loosening of the catheter or the catheters even falling out. And then again, it was removal, early removal. And this really helped us because in accordance with SCIP core measure number 9, that you want to get catheters out within 48 hours, this was exactly what CMS was mandating. Early on, we had a decrease, and I think that was part of the Hawthorne effect. People were noticing that we were piloting on our surgical floor, counting Foley catheter days. We were really auditing how the catheters were being used. But by 2010, we had a significant reduction from a rate of 2.6% UTI risk in 2008 down to 1.5%. And that was looking at another 2,400 patients which were captured within our database. This was a 62% reduction in catheter-associated urinary tract infections within our hospital. Not only that, but at this point, we brought this to our chief financial officer, because we were able to create a business case behind quality using ACS NSQIP. And so what we found is that with inpatient Foley catheters developing a urinary tract infection, there was an increase of $52,000 in institutional costs related to that infection. Not only that, some of our patients who went on to develop a bacteremia or an infection in the blood because of the urinary tract infection, some of those patients actually died. And when we started antibiotics on many of the other patients with urinary tract infections, they developed Clostridium difficile. So developing a urinary tract infection isn't innocuous. It can really develop into an event which may lead to mortality. So we were really looking at not only saving costs, improving quality, but saving patients' lives. Communication, that's the key. When you get your ACS NSQIP program, reach out to the college, ask for the resources available, use the best practice guidelines, which are easy to follow, and bring those guidelines back to your performance improvement committees and use those as a model or guide to set up a protocol. Talk to your surgeons. Surgeons love data. Bring it to the nursing rounds. Allow the nurses to be empowered so that they feel like they can be part of this program in which they're preventing hospital-acquired infections. And then go out into the community. Talk to your patients. Tell your patients you're part of the ACS NSQIP and what you're doing in order to prevent infections. And I think one other important thing that we've done besides going out in the community is we've talked to the insurance carriers, the payers, and we said, look, we're using a best practice guideline from an evidence-based, risk-adjusted database, being transparent with our outcomes, and we're trying to save money, we're trying to improve patient lives, and we're improving quality, and here's the data to support it.